Recording in progress.
Good evening, everybody. Welcome. So tonight, the Epilepsy Foundation Eastern Pennsylvania has our Adult Epilepsy Conference. Thank you so much for taking the time to attend our conference tonight. Just a little bit about us before we get started. So we're your local affiliate to the National Epilepsy Foundation of America. We're here to support families and individuals experiencing epilepsy. We provide a lot of education, advocacy, social programming, mental health programs, and we serve 18 counties in Eastern Pennsylvania. So here are some of the programs and services that we provide. We do Project School Alert, which is our seizure recognition first aid training for schools. We train school nurses, teachers, personnel, and students, even bus drivers. So we love to train schools. We also have a first responder and law enforcement training. We provide numerous support groups. Some are in person, some meet online. We have advocacy at the foundation, and we're currently working on legislation that would mandate school personnel to be trained in seizure recognition first aid training. We do educational conferences and webinars. We connect families and individuals to different resources in their community. We have our Camp Achieve program for 8 to 17-year-olds diagnosed with epilepsy. It's a 1-week sleepaway camp. We have 4 mental health programs for adults diagnosed with epilepsy. We have a young adult retreat. It's for 18 to 30-year-olds that are diagnosed with epilepsy, and an adult wellness weekend. And that's for those over 30 who are affected by epilepsy. So you could, for people that have epilepsy, but also it's open to parents of children with epilepsy and people that have partners that have epilepsy. Just really quickly, here's some of our contact information if you needed to get in touch with us to get some resources. Feel free to email me, get in touch with me. And also the Epilepsy Foundation of America has a really wonderful website, epilepsy.com, that has a lot of great information. Okay, so here's the agenda for tonight, just so that you know what the schedule will be. Here it is. So we have a really great lineup for you tonight, and we will get a little bit of a break as well. Okay, so it is my pleasure to introduce our first speaker tonight. So Dr. Kartik Sivaraaman is a board-certified neurologist and epilepsy specialist at Abington Neurological Associates in Pennsylvania, where he also serves as vice president. Dr. Sivaraaman previously had academic positions at Rutgers Robert Wood Johnson Medical School and Virginia Commonwealth University, where he also directed an epilepsy monitoring unit. He completed advanced fellowship training at Thomas Jefferson University Hospital and has contributed to clinical research and publications in epilepsy and neurophysiology. He is committed to providing compassion, patient-centered care, and helping patients and families better understand neurological conditions. So thank you so much, and I will hand it over.
Thank you so much, Rena. Thank you for having me. Thank you all for coming. Let me go ahead and share my screen. Desktop. Rena, is my presentation visible?
Yes, it is.
All right, good. All right, once again, thank you all for coming. So we're here today to talk about the rescue medications and how to use them in real-time scenario as a practical guide. The objectives I have are how, first of all, understanding what is a seizure emergency, a seizure cluster, and this is when to use this rescue medication, how to administer them, then stemming from that, if it doesn't work, what to do as the next step, and finally, the most important, what is a seizure action plan? I'm assuming most people have been here before, so they all know what a seizure is. It's more like a short burst of brain's abnormal electrical activity in the brain. And that, for the sake of understanding, we can consider like a short circuit, which causes an abnormal brain electrical discharge. And depending on the part of the brain that is affected, there can be differences in the manifestation. It can be a full-blown seizure. It can affect how the patient moves, feels, responds. The best part, and thank God for that, most seizures stop on their own in a very short span. The brain learns how to stop it and it stops it very effectively, but unfortunately, it doesn't happen all the time. Switching gears a little bit, epilepsy is stemming from a seizure. When I call somebody as an epileptic, when in the medical language, this means that he or she has an inherent tendency to have seizures, unprovoked seizures, affects approximately 1.2% of the population. And I've specifically mentioned here about drug-resistant epilepsy, which means they've tried a few meds, usually 2 to 3, and they continue to have seizures. That is 30 to 40% of the 1.2% of the general population that have seizures. The reason I mention this is because it becomes relevant when we try to identify who gets the rescue medications, which we will see just now. First of all, what is a rescue medication? It falls under the class of these drugs called benzodiazepines. Now, what they do is primarily stop the seizures from happening or reoccurring in the presence of a seizure cluster. Now, it is a medication that is used on an emergent basis. It is not something that we use on a daily basis to stop a seizure. In fact, it loses its potency if you use it too frequently. I did add a small comment there that rescue medications are grossly underutilized for reasons I will be talking about, and how we can actually encourage their use in the appropriate scenarios. Now, when we talk about rescue medications for seizures, the primary reason that's administered or it's FDA approved for is what we call a seizure cluster. Now, it's also called acute repetitive seizures, back-to-back seizures, multiple seizures, serial seizures, so many different names for it. But in general, it means a lack of control, or there is a deterioration in the control of seizures. Just as it has so many names, the definition itself is a little bit nebulous, as you can see here. So there are two different broad definitions that we're given. One, if the person has 3 or more seizures in 24 hours, or in other words, more than one seizure in an 8-hour period. The reason they picked 8 hours is because if a seizure happens within 8 hours, the same seizure twice, it usually tends to start from the same region as opposed to a different part of the brain. That's one of the reasons they came across this. But there are other definitions too. Some studies have included more than 2 seizures in 6-hour period as well. Now, this definition, though it seems meaningful, is not always relevant because there are unfortunate people who have at baseline a lot of seizures, in which case 3 or more seizures in 24 hours is not an apt definition for a seizure cluster for those people. So they came up with a statistical definition, which means a 3 to 4-fold increase from the baseline seizure frequency. This kind of is a better definition, but currently the final consensus is an increase in seizure frequency compared to the patient's usual seizure pattern. So, which obviously is telling us that a seizure cluster is tailored to every single individual person with seizures. It is not a universal definition. This is something the physician who's caring for the patient will have to come up. We'll be talking further more about this as we go. Now, who gets these seizure clusters? Technically, anybody can, but there are certain risk factors for this. Patients with, in general, intractable epilepsy, as I mentioned in the very first few slides, when they have a medically refractory epilepsy, the chances are high. Extratemporal meaning something outside the temporal lobes. Temporal lobes are the sides, which is the commonest region where seizures happen. Outside in the frontal lobe, for instance, if seizures start, they tend to present like that. When seizures happen in multiple regions of the brain, those can present. Excuse me. And lastly, I've also mentioned cortical dysplasias, which is more like a developmental abnormality in the brain that can also lead to these kind. This is just a common factors, not the entire list. In addition to these major risk factors, there are other things in our day-to-day lifestyle which can also increase the probability of having seizure clusters. Having an illness in a person who has epilepsy, significant stress, lack of sleep, menstrual cycle. That's a common problem because when the hormones fluctuate around the menstrual cycle period, there are two hormones like estrogen and progesterone, as everybody knows. When the progesterone level drops, progesterone has a quietening effect on the brain. When that drops down, seizures tend to happen, migraines tend to happen, premenstrual syndrome, mood changes, all those things. Uh, Next is travel, stress of travel. Unfortunately, missing a dose. Everybody is human. Errors happen here and there. Alcohol, once in a while, somebody indulges, that can lead to a cluster. All of these are common day-to-day factors which can lead to development of clusters. So whatever be the cause of it, what is the final endpoint? Why are we worried about these seizure clusters? It's because it leads to increased hospitalizations, ER visits, productivity. Once somebody has a cluster, it takes time for them to recover from the cluster. So loss of time. But from a patient as well as the physician perspective, the most dreaded complication is status epilepticus, which is like back-to-back seizures, which eventually can also cost lives in people. We call that SUDEP. Very unfortunate. Rarely happens, but it does. I think Dr. Ney once gave a lecture here regarding this. Um, Shifting gears again a little bit, this is a patient survey study that was done a little while ago where all different kinds of um, you know, problems that patients and caregivers face were brought out. See, I mean, in general, they have trouble traveling, inability to adopt a lifestyle that a person without seizures has. As I said, travel, being independent. Um, the interesting point is once we are able to give them confidence with the administration of rescue medication, like clusters are going to not happen as much, maybe some of these um, psychological as well as day-to-day factors will get better. That is the hope. Now, here's a curveball, which is like patients with seizure clusters can have a better outcome of epilepsy surgery. I guess there is a silver lining to everything. So, this stems from the idea that if several seizures arise from the same region in succession, maybe resecting that region can cause seizure freedom. This is a digression. I just put it in there just to give a sense that there is a positive side to this thing as well. Um, Now, we have defined what seizure clusters are. In other words, what constitutes a seizure cluster. But there is a challenge here. The challenge being the difficulty with identification of seizure clusters. Whenever patients have seizures, we always advise them to maintain a log to document how many seizures are happening um, in a specific time frame. But it's not always done by everybody. I do have patients who do it very meticulously, but they're not everybody for several reasons. I understand. Sometimes patients are amnestic to the seizures, like amnestic meaning they don't remember the seizures. When seizures happen, the electrical abnormality in the brain deletes the memory off, so they don't know when they come out of the seizure that they've had a seizure. The way I explain it to patients is when you basically type on a Word document and the computer crashes, things are not saved, you lose the data. It's like that. Sometimes seizures are nocturnal, meaning it's happening in sleep. In that scenario, again, obviously, we wouldn't know if they're happening. And different caregivers can be there for pediatric patients at different times. And some of them are very good at documenting it. Others may not recognize the seizures as well. That is another thing. And lastly, it's not always spoken about during the office visits, review the log and things like that, uh, which is also being documented in the literature as can happen. Now, as I already mentioned, the problem is when seizure clusters happen, it can progress into status epilepticus. And when status epilepticus, meaning recurrent back-to-back seizures happen, then there can be neurological damage stemming from the seizure itself. Seizure clusters can cause injuries even otherwise. And obviously, the rate of hospitalization goes up with these things. Now that we have kind of defined about seizure clusters, the next thing would be to move to what is called a seizure emergency, which stems from a seizure cluster. So I already talked about what a um, status epilepticus is. That would be a seizure that lasts longer than 5 minutes, as I've put in there. And for patients with absence kind of seizures, it can be 10 minutes. But bottom line, this is a seizure that is not automatically controlled or stopped, and the process is ongoing at this time. Now, when status epilepticus happens, people can appear to have two different seizures, but they don't recover in between them. It's a continuous absence of recovery of consciousness between the seizures. And finally, other injuries, all these can happen from a seizure. These constitutes a seizure emergency. Now, so on one side, we have seizure clusters, which can become a seizure emergency. But there is a period in between where we can probably intervene to prevent a cluster from going into an emergency. That's what we are kind of attempting here. Now, I put in a question mark as a prolonged seizure. So these are seizures which are not stopping at what is usually normal for that particular patient, but they have not extended to becoming an emergency. So they're somewhere in between. These are poorly defined in the literature. Consensus guidelines are just coming out now, but these are the prolonged seizures, and these are specific targets with these rescue medications. So now that we have defined the seizures, let's now talk about the rescue medication. One of the problems I have with an online talk like this is I'm not seeing the faces of all the audience. So I'm in a live conference, we are clear about how the understanding happens, looking at the faces of people. Here, that becomes a little challenging. I hope I'm making sense so far. But anyway, uh, we've defined a cluster, we've defined a prolonged seizure. So these are the kinds of patients who would benefit from a rescue medication. Now, I've put in as a third point patients identified by the neurologist, which is actually the crux of this whole thing. As I mentioned, this has to be tailored for every individual patient. Now, preparation matters, right? Seizures are unpredictable. Nobody knows when they are happening, which is kind of the major challenge with seizures. And here we have a technique, a methodology, which can potentially stop, break the cluster, stop a prolonged seizure, and hence can reduce ER visits, reduce complications. Now, I said preparations matter because, see, our brains broadly classified work in two different ways, right? There is a cognitive way that we work. We think and we act, and it's a very thought over process. A lot of our actions during the day are like that. But many of the other actions are automatic too. We have learned it so well that we are doing it almost automatically. Responding to a seizure emergency, I would always want the patient and the caregiver to be so well prepared so that it's almost like an automatic response that you don't have to think about it. Uh, and that comes with planning, preparation, understanding. And that's what we are attempting to do here. Now, as I said, all the rescue medications fall under the category of benzodiazepines. And these are chemicals which act on something called the GABA receptor. This schematic here shows that when a benzodiazepine binds to a GABA receptor, it allows chloride ions to go into the cell. See, brain cells are all like batteries. They all have an electrical charge that is produced by all these different ions, sodium, potassium, calcium, and chloride, and all these things. And when these benzodiazepines bind to the receptor, chloride enters and it causes the cell to quieten down. That's what we want it to happen, and helps stop an ongoing seizure or a seizure cluster from progress. Now, we currently have 3 FDA-approved medications for treatment of seizure clusters. And what we use for a prolonged seizure is just an extrapolation of that. We don't actually have an FDA-approved drug for it, but they all work, as I'll show you. For the longest time, we were using before the approval of these drugs, neurologists were using other things like, oral drugs, uh, um, preparation of buccal midazolam, meaning it's just a liquid that is squirted into the mouth of the patient, usually used in the pediatric population. Even now in Europe, a lot is used like that. If the clusters are not frequent enough, even now we use oral medications like clobazam or Klonopin. For instance, somebody around the menstrual cycle has like 3 seizures in 3 days as a typical pattern. They may not need an intranasal thing. They can be given just an oral pill around the cycles to reduce the seizures from happening. But we will be primarily focusing on the other 3 rescue medications today, which is intranasal midazolam, intranasal diazepam, and lastly, the one which has been there for a while is rectal diazepam. All right. Now, before we go to the rescue medication, what do you do when you witness somebody having a seizure? First thing, obviously, stay calm. Place the person in a safe place on the side. Remove hazardous materials nearby. And lastly, never put anything in the mouth. Okay. Once the location and the patient is secure, only then we progress into administering the rescue medications. All right. So now we'll actually talk about the individual rescue medications themselves a tad bit, and then we'll come to the seizure action plan. So first we'll talk about Diastat because this was the first approved medication all the way back in 1997. And it was the first medication that could be used in pediatric population as well. It's a gel formulation that is administered into the rectum of a person who is seizing. And you can see the indication is also a little bit nebulous, like acute treatment of intermittent stereotypic episodes. So the original study here basically showed that administration of diazepam caused the probability of seizures to go down. They call this Kaplan-Meier curves. One means there is no seizure. So when you administer Diastat, it looks like the curve flattens out and the risk of seizure goes down. And it's pretty quick to start working. Within 5 minutes, it starts working, and it's usually dispensed in a weight-based formulation. Depending on the weight, you dial it to a specific amount as a prescription. And when the need comes, it is administered through the rectum. The patient is laid on the side, the tip is lubricated, inserted into the rectum and the medication is administered. And then you hold it so that the drug is able to act and enter the bloodstream. Now, even though it is effective, just by description alone, it's very obvious that it is not very socially acceptable, right? This particular drug, when it was shown in studies, most people felt uncomfortable about it, especially when it happens in the public settings. In a school nurse survey, this nurses, students had primary concerns. There was legal concerns. Staff were hesitating. So even though it's a very effective drug, there were hindrances. There are roadblocks to administration of the drug, to the point that even neurologists actually felt, it's not getting used. So they tried to give alternatives to it. It is still very effective and is still used in certain populations of patients who don't have much public presence. But again, the social aspect of the drug is a definite roadblock to using rectal diazepam, which has always been the case. And that is why there was always a search for a much easier way of administration, and that brought the field towards nasal rescue medications. Obviously, they are way more convenient to administer than rectal formulations. They are socially definitely more acceptable, does not require much of a patient cooperation. Caregiver training is minimal at best and very little risk of injury. All these make it much, much better way of administering the drug than giving a rectal formulation. All right, so nasal mucosa is pretty vascular, meaning has a good blood supply. So something given in the nose gets very easily absorbed. And in addition to the nose, the respiratory mucosa is basically the lining. That's what we call mucosa. So the nasal lining and the respiratory lining deeper inside, they all absorb the drug very, very well. And whatever is swallowed also gets absorbed. So the drug that is given is definitely mostly making it into the bloodstream in a very effective fashion. Now, one interesting point to note here is that whatever goes into the gut and gets absorbed gets metabolized by the liver, right? So this is the problem with diazepam that's given rectally as well. When it's given, some of it is going to get metabolized, and the nasal pathway of administration kind of circumvents this problem. Now, as I said, easy to administer, and the first approved medication for this in 2019 was this intranasal midazolam, which is called Nasalam as a brand name. So it's basically you hold it in place once the patient is well in a safe location and safe place, and you just press it and that's it. It just goes. And it's a single-use formulation. Nasalam, it comes in one dose for all patient weights, and it's, as I said, extremely easy to administer. It was approved, as I said, in 2019. I mean, the studies were done. As opposed to placebo-controlled patients, patients given Nasalam had 53.7% chance of achieving seizure termination in 10 minutes. Now, just like the graph that I showed for diazepam, the rectal diazepam, you see the graph here also shows when administered intranasally, the risk of seizures is going down with time. Didn't mean to do that. Okay, sorry. With time. All right, so what adverse effects do we expect from giving something intranasally? Usually just nasal discomfort, some abnormal taste that people have, but really nothing major or serious. And I'll talk a little bit more about respiratory depression towards the end of this, but in general, no respiratory depression. Okay. Now, when intranasal midazolam was approved, there was another group of people working on intranasal diazepam as well. Obviously, right, so this drug has already been proven to be effective in stopping the seizures and clusters. It just wasn't an easily administrable formulation. It was in a rectal formulation. So they were trying to work on something which is can be given nasally. And that led to the intranasal diazepam as well. Initially, there was difficulties. Some formulations did not work well. Eventually, they found out that using a specific surfactant called DDM and vitamin E, all of this together allowed for this drug to get well absorbed. And this is the graph that shows basically that intranasal and rectal ones, how they get absorbed and when they reach the bloodstream and the time it takes for it to get there. Now, the intranasal diazepam is called Valtoco, and unlike the nasalam, which is basically a single dose for everybody, this one is more of weight dependent, just like the rectal diazepam. Based on the patient's age and weight, a specific dosage is to be administered. And for doses about 10 milligrams, it's administered in one nostril and then the other nostril so that it gets to the final dose. All right. And the drug can be repeated in about 4 hours if need be. Now, these drugs, the diazepam rectal, intranasal, and intranasal midazolam, they have little bit of differences in the way they get absorbed and the way how long they last in the bloodstream. For instance, nasalam is very quickly absorbed, but it doesn't last a long time. While that is true for even midazolam given intravenously or intramuscularly, it's just a short-acting drug. But diazepam is a much longer acting preparation. So whether it's given rectally or it's given intranasally, it tends to linger around for a much longer period. But despite these differences, when they studied efficacy, for instance, in patients who had status epilepticus, they were all extremely good at stopping it. This one basically shows that the diazepam intranasal and midazolam, they were both very good. About 3 to 4 minutes, they were able to stop even a status epilepticus from happening. And the rectal one similarly was a little bit longer than the nasal ones, but it was also equally very effective. Now, there were some review articles which took all the data and compared the different drugs, but there is no head-to-head comparison between these drugs simply because the way the studies were done were a tad bit different, and the way the endpoint was met was also a little bit different. So they couldn't quite compare head-to-head, but in general, they are very comparable at stopping the seizures and the requirement of the second dose. And very importantly, all of them, that's why I marked it in circle, they all have a very, very minimal amount of side effects, which is also very, very important to consider when administering this drug. This one, I think I showed you already as a graph that, oh, sorry, this part was actually in the epilepsy monitoring unit. When patients get admitted to the epilepsy monitoring unit, they were administered the drug. And sure enough, like what I showed before, these these drugs were equally or in fact very effective in stopping the seizures. All right. So one of interestingly a new relatively new about a couple of years ago a study was published which basically said that regular use of these medications in patients who have clusters actually seem to reduce the clusters reduce the clusters themselves. This was interesting. I mean, as you can see here, day 1 to 90 versus day 271, the the frequency of the clusters seems to have gone down. CIVL stands for seizure interval in days. So instead of 12, now it's 26 days. And there's so many different, they don't actually have an explanation for this, but they came up with several possible theories of why it is. Maybe we are affecting the irritable center itself. Maybe we are making the patient more compliant, giving them more confidence. It is still being worked out, but this is an interesting finding. So if used appropriately, then it is likely to actually cause betterment of seizures themselves. Now, this study was primarily done for intranasal diazepam, but it is unclear if it's a class effect, it's only specific to this drug, all of those things are yet to be deciphered, but this was an interesting finding that I thought I should share with you all. All right, so we've discussed about the seizure clusters and emergencies. These are the indications to give these rescue medications, primarily for the clusters and extrapolation into prolonged seizures and emergencies. And once you have done that, what next? That's the next question, which is we have to continue to monitor the patient, stay with the person, allow them to rest, and you should have certain expectations. They are going to be drowsy, sleepy, because these drugs, the benzodiazepines, are also sedatives. So they, once administered, they can cause people to be a little bit drowsy and sleepy for a while. Now, confusion temporarily, but interestingly, the confusion is a little hard to decipher simply because some of that can be coming from the seizures themselves. The way I explain it to my patients is that once a seizure stops, the brain is practically rebooting itself, like what the computer does, right? Until the rebooting process is complete, the computer is not functional. So you have to wait for the reboot to happen. And that's exactly what happens in the brain. So there is going to be some confusion, maybe a little more than expected in the presence of these drugs, but maybe less if it breaks the seizures down. So this is something we have to watch for, but seizures should stop and gradual recovery is what is expected. Now, as I mentioned previously, side effects are very minimal for these drugs. You know, breathing problems are mentioned specifically because when these benzodiazepines are administered IV, like in the hospital, somebody is having a seizure, we give them the same benzodiazepines, usually lorazepam, a little bit different, but we give it IV. And there are cases, unfortunate cases, where the breathing drive goes down, breathing can be affected. In a hospital environment, that is fine, simply because we have ways to deal with it. But when we're talking about as an first responder, as an outpatient caregiver giving it, if that is a side effect, that's concerning. But fortunately, none of these drugs seem to have any significant breathing problems associated with it. Serious allergic reactions are unpredictable. If somebody has it, that is a concern, but again, low probability. But if there is a question, you should ask your physician who's giving the drug. Now, after this, and the very important aspect is we've administered the drug, we have to know now, is that enough? Should we do something else? And that's where we should know when to call for help. Now, you've if the seizure stops, if you had a prolonged seizure or a cluster and the seizure stops, great. Um, but if it continues, or if the person is not recovering consciousness and has another seizure, these are all suggestions that the seizure is going into status epilepticus. Now, despite the drug, it can happen, so you have to be watchful. So if a seizure lasts long, or if there are recurrent seizures without regain of consciousness, that's immediately, it's urgent to call 911. If there is severe significant injuries, other breathing issues, and the mental status after administering the medication, for instance, is not recovering, then those are all indications to call 911. Okay, now I wanted to put this extra slide in there because this is something I always caution people. You know, you discuss in the office, you've given them all the instructions, there is rescue medication being administered, but thank God the patient never had a cluster after that, doing so well on the medication. And what tends to happen is people forget about the cluster medication and don't check, and God forbid when you need it, you will find it's expired. So time and again, it's important to go back and check that the drug is around and it's not expired, so that God forbid if it's needed, we do have the ability to use it. Okay. Now, this part is important, creating a seizure action plan. Now, what is a seizure action plan? It's a written documentation which describes the kind of seizures that the person has, and what is considered a seizure cluster for that person. If you remember my initial slides, I specifically mentioned the definition of a seizure cluster is kind of nebulous, and it has to be tailored for every individual patient. So once we identify what constitutes a cluster for one individual, that goes into a written documentation called a seizure action plan. So you've now identified, you've given them a clear details about what constitutes a seizure cluster for that person and what is a prolonged seizure for that person. And when these happen, what medication to give. And after that, once you give the medication, what to look for. Whatever I gave over the last half an hour, 40 minutes as a talk is all given written down in a seizure action plan. And once it is documented that way, it is basically shared with people. So just to recapitulate, the description of the seizure, a seizure cluster, a prolonged seizure is all given. What medication to be administered when these happen is shared. And it should also have information about what to do after, including emergency contacts, the physician's name, uh, in case they have to reach the office. All of those is there in the seizure action plan. Now, this is something I always encourage patients to talk to their doctors about, especially in people who have recurrent or back-to-back seizures or a tendency to have that. And this, if you go to websites like epilepsy.com, they have beautiful formats for it. All we have to do is print it out and start filling it. It's a complete document in and of itself. It's extremely informative. And once you have this, you share it with caregivers, the school, anybody who can be in close proximity to the patient to administer the drug. It is a very, very informative document. And once this document is made, it doesn't stop there because every time you go for a visit, you want to revisit the action plan. The simple reason to do that is seizures are a changing target. People who don't have clusters can start having clusters. People who don't are having clusters can have a change in the pattern of it. So just because we made it one, that's not end of the story. It has to be revisited time and again to make sure it's up to date and still remains relevant to the person we are treating. So as I mentioned, we have to, once the document is made, we share it. We share it with family members, teachers, school nurses, friends. And in addition to understanding when to administer the drug, they also need to know how to administer the drug. So many platforms are available for this. When we were in Rutgers, there was like a, a support group, and those places are where patients and caregivers can understand this and try to actually use it to get comfortable and confident about how to use these Cs. I mean, how to hold it, how to squirt it into the nose, and things like that. And if you contact the companies, they actually send uh, trial ones which do not have the drug in them, but it has the mechanism and the structure, so it's easy to practice on somebody else, so that you get confident about how to use it. Um, and so many videos in their websites, in Epilepsy Foundation, they all have training videos on how to use it as well. And Epilepsy Foundation actually offers a certification as well, if people are interested. All right. Now, once you get it, they can be well stored at the room temperature. Just avoid extreme heat and cold. Don't put it on the dashboard of your car, and keep it in the original packing. Don't open it and keep it. It loses its protection that way. All right. We're coming close to the end of the presentation. I thought I'll add a couple of slides about the common questions that I get asked by people. Um, One of the commonest ones I get asked is, what if I use the medication and, the first time over, they got anxious and they gave it. Probably the person didn't need it, but they gave it. What do I do now? Nothing to be done. As I said, there is a the significant safety threshold for these drugs that usually is not a problem. But after that has happened and the patient is doing well, definitely talk to the physician to see if there's any modification to the action plan that needs to be done. The other common question that I get asked is, are these drugs addictive? Because benzodiazepine, like, you hear always about Xanax abuse and addiction and stuff. Can these drugs be addictive? And the answer is no, because they are usually the max is 5 times a month, for instance. It depends on the seizure action plan we make, but in general, that's what it is. And if a person needs to use it more than that, then it's time to go back to the drawing board about the medications that are controlling their seizures themselves. As I mentioned, these are not drugs that are used to control day-to-day seizures. They're used only for a specific indication. That's why they are a rescue medication. So in a rescue setup, when it's used, it is not addictive. All right, so seizures are frightening, but manageable. Um, Preparation, as I mentioned, builds confidence. Education about these things definitely improves the safety for the patients. What we are hoping to see is with the every office visit, you define if the person is having a cluster, identifying who is having these clusters, using a formal action plan, and then disseminating that information to caregivers of the patient so that the drug can be safely administered. Lastly, always time the seizure, recognize the patterns, definitely talk to your physician about seizure action plan, and hopefully the use of rescue medication would benefit many patients. Further resources are available. This is my last slide. Thank you very much. Thank you all for attending.
Thank you so much. That was really wonderful. Now, this is the part where we have our Q&A. Unfortunately, I realized that we do not have a chat feature in this
Oh,
webinar. For some reason, it did not get set up. So what I'm going to have, everyone has to sign off and come back in because I did fix it on the back end and I had a participant sign off and come back in and it is working now if we do that. So what we're all going to have to do, I'm going to end the webinar and in 2 minutes, come back in because by then the webinar will be started up again. So for those that are on, if you have any questions, go ahead and put them in chat. All right, we'll give it maybe 2 more minutes. We're halfway there and people signing back on. Yep, and there's some questions coming through. So yeah, everyone, please place your questions in chat and we'll read them in a minute. I'll read, we have a good comment here. So this person said they don't have any questions. They wanted to thank you for your presentation. They said you were extremely clear and engaging, and they really appreciated your thoroughness of your content.
thank you so very much.
Okay, I'm going to start reading the questions here. Okay, so as a school nurse, should every student with a history of seizures have a seizure action plan and rescue meds ordered?
Oh, that's a very good question. So, not everyone with seizures. As I said, these rescue meds are specific for clusters and prolonged seizures, right? So, it is up to the neurologist to identify who needs it. But it's important for every one of those patients to be encouraged to speak to the neurologist to see if they need a seizure action plan. I mean, I have patients, for instance, who have a generalized epilepsy, who've had a couple of seizures in their life and have been seizure free for like 3 years right now. And I don't think they will require a rescue medication. But this is something that's what I was stressing about towards the later part of the lecture, that it's become very, very tailored to to every single individual patient. But please encourage them to talk to their physician to see if they need a seizure action plan and a rescue medication.
Okay, thank you. Someone asked if you were able to review seizure first aid for someone in a wheelchair.
Seizure first aid for a person in a wheelchair. That would definitely depend on. So when I said put them on the side, that would obviously not be applicable for that person. Being in a wheelchair, in a way, prevents them from falling, which is good. But at that point, I think if they're actively having a full-blown seizure, so seizures, as you know, can be of so many different kinds. If it's a full-blown generalized seizure, I think it's probably safe to leave them in the chair until you're able to get help. For you to attempt to move them yourself is going to be much more of a risk than just leaving them in the chair. And just turn their face towards one side, just to make sure they don't swallow their own secretions in the wrong passage. And outside of that would be the same as seizure action plan.
Hey, thank you. Okay, a lot of thank yous and great presentation in the comments here. All right, here's another. So this person said that their issue recently has been aura clusters. They haven't had a full seizure in 10 months, but they still have auras about every 3 weeks, and they're asking, are these seizures? The auras usually are 3 or 4 over short periods over a day or so.
Yes, this is not directly related to our topic, but yes, auras and seizures are not different. See, an aura, as I said, a seizure is an electrical problem that starts in any region of the brain. And the brain usually has two parts, right? There's a motor part and a sensory part. In other words, there are parts of the brain which perceive sensations. I'm seeing something, I'm feeling something, or even an emotion is kind of considered that way. So a seizure arising in any of these regions is what we call an aura. So essentially, every seizure, every aura is a seizure. It's a small, brief seizure. But if it's happening very frequently, it is time to probably talk to your doctor to control them.
Okay, thank you. All right, the next comment, and then there's a question. So this person says they have a student with a seizure action plan that says to give the rescue meds for seizures more than 3 minutes. These seizures are hard to follow because how they typically present is with focal type seizures, and they often look different each time, staring off, zoning out. My question is it ever too soon or inappropriate to give a rescue medication if you're seeing symptoms, but it's not a traditional tonic-clonic seizure?
Well, this again is, again, I'm stressing on the fact that it has to be tailored for the person.
Right.
Every seizure cannot be different from another. That kind of goes against the actual physiology of the seizure itself. Assuming there is just one region of the brain or a couple of regions from where the seizure starts, every seizure cannot be totally different from one another. There is, in fact, one of the uh, important aspects of a seizure is the fact that they are very stereotyped. They happen one after the other in a similar fashion. So, if there are multiple seizure kinds, if you look at the action plan, it clearly states what are the different seizure types to look for. And for each specific type, how long can you wait before you administer the drug? That is how it has to be dealt with. As I said, it's no harm in giving it sometimes, occasionally, it doesn't harm it, but this is something you definitely need to tailor for that particular individual.
Okay. I am going to ask just a few more questions just so that we can stay on schedule. And then any questions that are not answered, I'll get in touch with Kartik and then he can give me the reply and I'll send it out to everybody. But I want to stay on schedule here. All right, here's another question. Do the rescue meds have side effects on mood like a lot of the daily seizure meds?
Not much. Even if they do, the primary thing is about sedation, but they are short-lived and designed to be that way, as I said. So long-term consequence, like what you see with day-to-day medications, is not really applicable here.
Okay, thank you. All right, so we are going to have a short break. And like I said, I will take the unanswered questions and I'll get the answers out to everybody tomorrow. Thank you so much for your presentation. We really appreciate all your knowledge. So we are going to take a 5-minute break and then we'll continue on with the conference.
Thank you so very much for having me. Have a good night.
Thanks, everybody. Okay, welcome back, everybody. I'd like to officially introduce our next speaker. So now we have Dr. Itai Loushy. He's an assistant professor of neurology and epileptologist at Thomas Jefferson University Hospital in Philadelphia. He specializes in the care of patients with epilepsy, including advanced diagnostics and treatment options. Today, he will be speaking about the role of genetics in epilepsy and what it means for patients and families. So, welcome, and the floor is yours.
Thank you. Thank you so much for having me. Let me share my slides. All right.
Looks good.
Okay, good. So good evening, everyone, and thank you for being here. Today I'm going to talk about genetics in epilepsy, what that actually means, when it matters, and how it can sometimes guide care. Many patients hear the word genetics, and understandably, they have a lot of questions, right? Does this mean that the epilepsy runs in the family? Should my children be tested? Will this change treatment somehow? So, over the last decade, genetics has become an increasingly important part of epilepsy care. But it can also be a little bit confusing because the field is evolving very quickly. So the goal of this talk is actually to give you a clear and maybe practical overview of genetics in epilepsy. And not so much, the complicated biology behind it, but the part that is most relevant to patients and families. So I'll walk today through several questions that patients and families often ask about genetics in epilepsy. First, we'll talk about what genetics actually means, since that word can mean a lot of different things. Then we'll discuss when genetics may play a role in seizures and when doctors start thinking about genetic causes. And after that, we'll review the available tests and what results can look like. We'll also talk about how genetics information can sometimes guide treatment and care. And finally, I'll show a real patient example. Now, let's start with a simple question. Why do we even talk about genetics in epilepsy in the first place? So epilepsy is not a single disease. It's a group of conditions that all can cause seizures, but the underlying cause can be very different. Some people develop epilepsy because of a prior stroke or a brain injury, a tumor, a scar in the brain, right? But in many patients, especially when imaging, MRI looks normal, then the seizures can be related to how the brain is wired at a biological level. And that's where genetics can come in. So understanding genetics can sometimes help us answer important questions, such as, why is this person having seizures? Is there a specific diagnosis? Are certain treatments better or worse for this specific condition? Does this affect other family members? But it's important to emphasize something early on. Genetics is only one piece of the puzzle. Not all epilepsy is genetic, and genetics doesn't hold all of the answers. So to understand genetics in epilepsy, we first need to briefly talk about what genes actually are. Now, genes are essentially instructions stored in our DNA. You can think of them as a kind of maybe an instruction manual that tells our cells how to function. Each gene contains the instructions for making proteins. And proteins are the molecules that actually carry out most of the functions of the body. Humans have about roughly 20,000 genes, and many of them are involved in how the brain develops and how brain cells communicate with each other. Now, because seizures involve abnormal electrical activity in the brain, changes in some of these genes can sometimes affect how the neurons function, and they can increase the risk of seizures. So how does that happen? So seizures happen when groups of brain cells become too electrically active and synchronized. Many genes in the brain control proteins that regulate this electrical activity. For example, some genes control what we call ion channels. There are tiny gates on the surface of the neuron that allows a bunch of electrolytes like sodium and potassium or calcium to move in and out of the cell. Now, these movements of the ions are what actually generates the electrical signal in the brain. So if a gene change alters one of these proteins, then the neuron can become more excitable than it should be. You can think of it as like the electrical system of the brain having the brakes weakened or its accelerator stuck in a way. And when that happens in certain networks of neurons in the brain, it can increase the chance of seizures. This is why many genetic epilepsies are sometimes referred to as channelopathies, meaning disorders of ion channels. Now, how does this happen? The most important misconception about genetics is that people often assume that it means that the condition runs in the family. But in epilepsy, that is often not the case. There are three main possibilities. First, a genetic change can be inherited from a parent. Now, this does happen in some conditions. Second, and this is actually pretty common, is that the change can occur for the first time in that specific individual. We call this a de novo mutation. It simply means that the change happens spontaneously when the embryo formed. And in those cases, neither parent carries the mutation. Now, the third situation is a bit more complex. Some epilepsies involve many small genetic factors that increase the susceptibility rather than a single gene causing the condition. Now that we've talked about what genes are and how genetics, changes can occur, the next question is how genetics actually show up in epilepsy. And there are basically two main patterns that we see. The first is a single gene epilepsy, where a change in only one gene plays a major role. Now, these can affect how the neurons function, like in Dravet syndrome, where a mutation in one of the proteins or one of the genes that codes for a protein, namely the SCN1A gene, which affects sodium channels. So when this happens, it can cause seizures, or it can affect how the brain develops, like in tuberous sclerosis. The second group is genetic generalized epilepsy. In these conditions, there usually isn't one single gene responsible. Instead, multiple genes, each contribute a small amount of risk, is at play. And a common example is juvenile myoclonic epilepsy. So the key idea is that the genetics can either act as a single clear cause or as a more complex background risk. And that gives way to the question, when do we actually suspect that genetics play a role with a patient? So we don't do genetic testing for every person with epilepsy, right? There are certain situations where we start to think more strongly about a genetic cause. One is when seizures begin very early in life, especially in infancy or early childhood. This is a clue. Another clue is when the MRI is normal, meaning that we don't see a structural cause like a scar or a tumor or a stroke. Another option is if the MRI shows a change that is specifically seen with a type of genetic diagnosis. We also think about genetics when someone has multiple types of seizures or when epilepsy is associated with developmental delay. And sometimes also a family history of epilepsy can also point towards genetic contribution. None of these factors alone prove that epilepsy is genetic, but when several are present, it often leads us to consider genetic testing. So when we do suspect a genetic cause, the next question is, how do we actually test for it? Now, when we decide to do genetic testing, there are several different types of tests that we can use. The first one is a multi-gene panel. This actually looks at specific groups of genes that are already known to be associated with epilepsy. This is often the most targeted approach and the one that many physicians or geneticists choose. There are certain considerations to why choosing this rather than the other. We're not going to get really into specifics. Another type of test is exome sequencing. So the exome sequencing actually looks at the part of the gene that codes for proteins, the actual manual itself. These are the regions that most disease-causing changes occur. Now, the next test is a little bit more comprehensive, genome sequencing. It goes even further and analyzes nearly the entire DNA sequence, both the DNA that can code for proteins and also the DNA that doesn't code for proteins, which is a lot. And finally, there's a test that is called chromosomal microarray. And that is a different type of test that actually looks for larger missing chunks or duplicated segments of the DNA. Now, there's no need to remember the names of these tests. The important point is that different tests look at DNA in a different way. And in practice, the choice of the test depends on the clinical situation, and it's usually guided by a clinician that is expert in genetics. Once testing is done, the next question in hand becomes, what do these results actually mean? So when genetic testing is done, there are three main types of results that we may see. The first is a pathogenic variant. This means that the lab found a genetic change that is known to cause the disease. Now, in this case, we may be able to make a specific genetic diagnosis based off of the pathogenic variant. The second possibility that the genetic testing might show is something that is called a variant of uncertain significance, or a VUS. This actually means that a genetic change was found, but we don't know yet whether this specific genetic change actually causes the disease. Once our knowledge improves and we gather more and more data, some of these variants of unknown significance can later be reclassified, such as, a VUS being reclassified either as a pathogenic variant or as a non-pathogenic variant. The third possibility is a negative result, meaning that the test did not identify any relevant genetic change. This is actually quite common and does not necessarily mean that the epilepsy is not genetic. It just says that the responsible gene has not yet been discovered or cannot be detected with our current testing. Or it can mean that the epilepsy is not a genetic one. We cannot tell for sure if the testing is negative. Now, if we do find the genetic diagnosis, the question is, does it actually change anything? Now, one of the most important reasons to identify a genetic cause is that the genetic cause can sometimes directly affect medical care. Not in a lot of cases, but in some. So in some conditions, it can help guide which treatment is more effective. For example, there is a type of epilepsy called GLUT1 deficiency, which is a type of genetic disorder that can cause epilepsy. And seizures actually occur because of the brain having difficulty using glucose. In these cases, ketogenic diet can be very, very, very effective. So this can actually guide care. Now, in Dravet syndrome, for instance, caused by mutation in the SCN1A gene that we alluded to before, some medications can actually worsen seizures. So knowing what the diagnosis is helps us avoid medications that might make the situation worse. Now, in many genetic diagnoses, epilepsy is a part of a broader syndrome, right? That syndrome can affect the eyes, the heart, the skin, other organs. So having this genetic diagnosis actually helps us to monitor for other medical issues. A genetic diagnosis can also help us understand the expected course of the condition. In some cases, it may allow patients to even participate in clinical trials or targeted therapies. So in some situations, genetics allows us to move forward with a more personalized or precision medicine. Often it is not the case, but sometimes it is. Now, beyond medical management, a genetic diagnosis can also have other important implications for patients and for families. One of the practical aspects is understanding, the recurrence risk. In other words, the chance that epilepsy could occur again in future children. In some cases, that risk is quite low, and in others, it may be higher depending on the specific condition. Now, this information can really help guide family planning decisions, often with the support of a genetic counselor, right? Some families can consider options like IVF with genetic testing. A diagnosis can also help determine whether other family members should be tested or may be at risk. But just as importantly, there is often a significant emotional impact. Many families spend years searching for an explanation. So having a diagnosis can bring a sense of closure, and it can also help end the diagnostic odyssey, or so to say. It can also help reduce feelings of guilt or self-blame, especially for parents who worry that maybe something they did caused the condition. And in some cases, it allows families also to connect to support groups and communities of people going through similar experiences. Now, although genetic testing can be very helpful, it's important to understand its limitations. First, we still don't know all the genetic causes of epilepsy, so a negative result does not rule out a genetic cause. Second, sometimes testing identifies a variant of uncertain significance, a VUS, meaning that we found a change in the DNA, but we don't really know yet whether it actually causes the disease. In some cases, even when we do find a genetic diagnosis, it may not immediately change treatment. And the main benefit is just better understanding the condition. Genetic results can also sometimes raise new questions rather than provide clear answers, which can be a little bit frustrating. And finally, there are some, insurance considerations, particularly for life or disability insurance, which these things are most often discussed as a part of the genetic counsel prior to getting tested. I can talk about that more later. So while genetic testing is a powerful tool, it doesn't always provide a simple or a definitive answer. Now, the current expert recommendations suggest that individuals with unexplained epilepsy should be offered genetic testing, regardless of whether the seizures began in childhood or in adulthood. Genetic testing is most useful when it's guided by a clinician that is familiar with epilepsy genetics. For instance, I rarely send out genetic testing myself, and most often I consult with my peer who's a genetics expert. And that is very useful. That is also useful because this is a rapidly growing field. And Although genetic testing is increasingly recommended today, it hasn't always been used widely in epilepsy. Now, historically, there were several reasons for that. First of all, earlier genetic tests had a low diagnostic yield, meaning that they often, didn't find an answer. Testing was also pretty expensive, not easily accessible, and there was a limited availability of genetic counselors to help guide the tests and interpret the results. Now, because of this, many clinicians became used to thinking that genetic testing was unlikely to be helpful in most cases, and it often wasn't helpful in the past. But over the last decade or so, this started to change, to shift. Now, we've discovered many more genetics or many more genes that are associated with epilepsy. The technologies that we use for testing improved and the diagnostic yield increased. At the same time, testing has become more affordable and more widely available. So today, genetic testing plays a larger role in epilepsy care than it did in the past. That said, like many areas of medicine, the clinical practice takes time to catch up with new evidence, and we are still sort of in the transition. So we talked about a lot of things, but in order to bring all of this together, I want to show you a real example of a patient we had in our clinic. So this is the story of a 30-year-old woman with drug-resistant epilepsy since infancy, along with a severe developmental delay. Her seizures began very early, just at about 2 weeks of age. Now, when she was so they did the diagnosis when the physician saw abnormal movements, that these were confirmed to be seizures on an EEG. And she was later actually diagnosed with infantile spasms and went on to try multiple medications, and she didn't really have a significant improvement. Throughout childhood, she continued to have multiple seizure types, including tonic-clonic seizures, which are what was previously referred to as grand mals, tonic seizure, myoclonic jerks, all of which were very much resistant to treatment, including a vagal nerve stimulator, a VNS. Now, at around age 21, she had some improvement with a combination of lacosamide and the Valproex, two medications that we have for epilepsy. But she did continue having persistent myoclonic seizures, which is why she presented to our clinic. Now, myoclonic seizures, so for people who are new to this term, is actually the jerking of the sudden jerk of the body, and it can be very debilitating. It can also be mild, but it can be very debilitating, such as for her. Now, during the visit, her mother actually did share that, she had a lot of guilt because she smoked and she consumed alcohol early in the pregnancy before she found out she was pregnant. And she always blamed herself for her daughter's condition. So that was a pretty, tough conversation. Now, we performed genetic testing using an epilepsy gene panel in the specific patient, and the result identified a pathogenic variant in the CDKL5 gene, confirming a diagnosis of CDKL5 deficiency disorder, or CDD. Now, this is a very rare genetic condition associated with early onset epilepsy, severe developmental impairment. But most importantly, in most cases, the mutation occurs de novo, all right? De novo meaning that it is not inherited from either parent. So now that we had a genetic diagnosis, the next step was to understand what that diagnosis actually means. So let me briefly explain to you what CDD actually is. Now, CDD is a rare genetic condition caused by changes in the CDKL5 gene, which is located on the X chromosome. Now, this gene plays a very important role in brain development and in neuronal function. Now, in most cases, the mutation occurred de novo, meaning that it is not inherited from the parent. Clinically, this condition is characterized by very early onset epilepsy, often beginning in the first few weeks of life. It is also associated with significant developmental delay, as well as difficulties with movement, and in some cases, also visual impairment. So this diagnosis can help explain both the early onset of seizures and the developmental challenges that we saw in this patient. Now the question arises of why does having this diagnosis actually matter? So the diagnosis had several important impacts. First, it provided relief from guilt for the mom, right? The mutation was not inherited. It was not caused by anything that the parents did. And this actually helped the mother understand that her daughter's cognition was not the result of smoking or alcohol exposure during pregnancy. So that was a big thing. Second, it gave us a clear understanding of what the condition is, explaining both the early onset of seizures and the developmental challenges. It also provided important information for future family planning, since the risk of recurrence in this specific case is very, very, very low. The diagnosis also raised awareness of other associated medical issues for that patient, including the visual impairment, allowing for a more comprehensive care. And also, it did help the family connect to support groups and support networks for CDD, which resulted a sense of, like all of these diagnoses, when you think that you've got a rare disease, it can cause a lot of isolation. So these support networks can really help with dealing with that isolation and can provide emotional and social support. So that was pretty important. And finally, it also opened the door to targeted treatment options with a medication, specifically ganaxolone, which is indicated for that condition specifically. So she received this medication, and it actually helped the myoclonic seizures that she came with. So I would like to summarize before I take your questions. A few key points. Firstly, some epilepsies have a genetic cause, and understanding that can really help us better understand the condition we're dealing with. Genetic testing can sometimes help guide diagnosis and treatment, although it doesn't always provide clear answers. It's important to know this limitation. And importantly, genetic diagnoses can have both medical and personal impact. They can affect treatment decisions, and they can also help families understand what's happening. And in many cases, they can, help relieve feeling of uncertainty or guilt, as we saw here in this case. And finally, this is a field that is rapidly evolving. We do expect genetics to play an increasing role or increasingly important role in epilepsy care going forward. But as I mentioned before, the clinical aspect, it takes time for clinicians to adjust to the new data and the new recommendations. So it is in the process of simmering through to clinicians at this time. I would like to thank you all for listening, and I would like to open the floor for questions.
Thank you so much, Doctor. That was wonderful. Okay, we do have a couple questions that have come through. So, the first one is, can a patient with mesial temporal sclerosis also have a genetic reason for epilepsy?
The answer is, in short, yes. So what happens is that mesial temporal sclerosis, usually we find it, and it is often the source of the seizures, but sometimes it's also a consequence of the seizures. So typically no, but in some cases, yes. And we have to take in account all of the clinical picture in order to understand, oh, was this mesial temporal sclerosis, or as we refer to it as MTS, is the reason that seizures are caused, or is this a secondary development due to seizures that started before the mesial temporal sclerosis? Um, Hopefully that answered the question.
Okay, thank you. All right, so this person wrote that they have two brothers with generalized epilepsy, one of whom started with absence seizures as a child, and their daughter, and this person's daughter has JME. I'll just read, let me read word for word here. Sorry. I myself do not have epilepsy, but may carry the genes. Is there any evidence that someone can carry susceptibility and have a brain that's more easily overstimulated, like increased sensitivity to stimuli or neurological fatigue, even without having seizures?
So that is a pretty is a pretty good question, and I would like to show you something in the slide, one of the slides. Okay, so when we talked about types of genetic epilepsies, here on the bottom part, you can see genetic generalized epilepsy that have multiple genes that are contributing to this situation. When we talked about ion channels, right, each little gene or each gene provides certain risk. And when there's several genes at play, then the epilepsy can occur. Now, with different siblings or with different family members that share many of these genes, the genetic generalized epilepsy, such as absence epilepsy or myoclonic or juvenile myoclonic epilepsy, both can present itself, sometimes in a little bit of different, way. We do often see people with JME or juvenile myoclonic epilepsy that the relatives have a different type of genetic generalized epilepsy. So that is quite common to see. Now, if the other question, if I believe, was, if I understood it, was, can this reflect or can this cause other types of issues other than seizures? So the answer is it's a little bit complicated because we do know that epilepsy is not only seizures and that's it. We do know that in JME there is a higher percentage of, for instance, ADD or ADHD. So there are other neurological, networks that can be affected. So that is, in the genetic generalized epilepsies. Now, due to like fatigue, I'm not sure. I think that fatigue, if you completely detach it, right, from seizure burden, I don't think that fatigue can be frequently seen. But more often than not, when a person has, a large burden of seizures, then fatigue can be seen either from the seizures or from the medication. But if a person doesn't have any seizures and doesn't, take any medications for epilepsy, and they do have a relative with genetic generalized epilepsy, I don't really see how fatigue can play a role. I hope that answers the question.
Hey, thank you. Okay, next thing here. Okay, so with genetic testing and those that were diagnosed very early with epilepsy in their lifetime, is the possibility of vaccine injury a consideration, and can genetic testing help identify the origin? Are genetics looking at the vaccines that are constantly being poured into the human body? This question arises when the origin of epilepsy is not clear.
So the notion of vaccine and epilepsy or vaccine and seizures is something that has been, described and that is known. Usually it's not because, or not usually, but all the cases that I know is not because of the, for instance, like the mRNA incorporates into the gene. Usually what happens is that the vaccine itself creates an immune response, which it should create an immune response, right? That is the target of the vaccine. But in the epilepsy causing cases, that immune response can actually trigger an immunity that can even attack some parts of the brain, and by that causing seizures. Now, this is not a genetic epilepsy. This is what we call as an autoimmune epilepsy. So genetics, while they may play a role, in suggesting what the susceptibility of the person is, for autoimmunity, it's not the direct cause.
Okay, thank you.
Yeah.
All right, we have a lot of questions here. Okay, let's see the next. All right. Um, okay, this is from someone. Both of my sons have been diagnosed with generalized epilepsy. They do not have the same father, so I feel guilty that I passed this on to them. I do not have epilepsy, and I don't know of anyone in my family that has it. Should myself and my sons have genetic testing? Also, are genes for migraines similar to the genes for epilepsy?
Let's begin with the second question, which is a little bit easier. Mostly the genes in migraines and the genes in epilepsy don't really co-align. But as I said, this is a growing field. So my answer right now might not be my answer in 5 years. The second question is that we do look at every case specifically. And I would suggest to go see your neurologist and ask them about that, right? And I think that several factors, go with it, such as is there developmental delay, or if there isn't a developmental delay, are there other features? And if it's just the seizure, what exactly are the seizures? So this is something, to be explored further with your neurologist. Now, a lot of people have that guilt, right? Oh my God, I gave my kids epilepsy, right? Um, you couldn't have known. And the fact is that when a child has a genetic generalized epilepsy, which is usually, from multiple set of genes, like we see in this picture here, um, the probability of having another kid with genetic generalized epilepsy, it's not zero, but it's not high. So you couldn't have known. And even if you've asked a neurologist, oh, one of my kids have just genetic generalized epilepsy, what is the risk that the other kid will have it? We would probably say there is a risk, but it's on the lower side. So I know it's tough, for me to tell you not to feel guilty, but you couldn't have known. Yeah.
All right, thank you. Where can a person get tested?
Um, so the testing is done through a genetics counselor. Even I understand about genetics and about epilepsy genetics. Even I don't refer people to these tests because there are so many tests and there are so many considerations. And usually the genetics counselor works with your specific insurance, and knows which labs work with your specific insurance and which panels, or if there's a whole exome or whole genome. And usually we have a fantastic geneticist, and she can often, direct people to the labs with the lowest copay. Sometimes it's even free. Um, so I would ask the genetic counselor. Yeah.
Okay. All right. This one says CSWS/ESES, diagnosed around 8 years old, She's 19 now, severely cognitively impaired. Is it a good idea to do testing at this stage?
Um, so again, I would ask the neurologist. If the patient or if the person did not yet transition to adult care from pediatrics, then maybe ask the pediatrician. If there was also the transition to adult care, then ask the adult neurologist. We more and more, me as an adult neurologist, refer more and more patients to it. Now, we do know that ESES can definitely sometimes be explained by a gene mutation. And I would definitely raise this question and yeah, and refer to a genetic counselor to go through with the testing. I think it's a good idea.
Okay. Can puberty cause a genetic change for epilepsy?
No, usually these changes happen in the embryo phase. So post-puberty, not likely.
How many genetic epilepsies are there that present in adulthood?
Um, I don't know, is the short answer. And I would like to show you this little picture. So I sort of breezed through it. If you can see my cursor, these are genetic epilepsies that were known, from 1997 to 2000 to 2011, 2017, 2023. And this is not even the end of it, right? We're at 2026, so the graph goes up and up and up and up and up. Now, many of these genes present themselves in early childhood, but if there is a genetic change that can cause only a minor change of that protein instead of a major change of that protein, then the epilepsy can present itself in a milder way or at a later stage of life. So I don't have an answer. I don't think anybody has an answer. But we definitely see genetic epilepsies that present themselves in adulthood. It's much more rare, true, but it does happen from time to time.
Okay. All right. I'm gonna pronounce this diagnosis, but I don't know if it's correct. But this person wrote, "My child was born with amblyopia, amblyopia, in his left eye,
Mhm.
and in his teens had a TBI developing temporal seizures at 18. Is there correlation between amblyopia and having seizures? His seizures are controlled by medication."
So his seizures were probably caused by a traumatic brain injury, a TBI, right? Many people with brain injuries end up developing seizures. And regardless of, what happened earlier in childhood. So I don't think that amblyopia does play a role here. Most probably it's the TBI or the traumatic brain injury. And the chance that genetics play a role here in that specific scenario is extremely low, very unlikely, because of the traumatic brain injury causing the seizures.
Okay, thank you.
Mhm.
All right. My sister had petit mal or absence epilepsy as a young child, and it disappeared after age 18. Can it return during a perimenopause or menopause? If yes, is this typical?
So that is also a very important question, why, genetics can play a very meaningful role. We do know that sometimes, for instance, childhood absence epilepsy, many children can, their epilepsy can disappear and never come back. And this is the natural course of the disease, and usually does not come back at a postmenopausal period. On the other hand, there are certain generalized genetic epilepsies, such as juvenile myoclonic epilepsy, that the likelihood that it will go away completely is lower than the syndrome that I just talked about, right? So it's tailored per, each diagnosis has um, its own set of prognosis. Having said that, I do have a patient I saw a couple of weeks ago that had, genetic generalized epilepsy that most children grow out of, quote unquote, right? Um, but she didn't. So it also happens. We often rely on statistics, and even if the person 90 or 95% chances that the disease will be self-limiting and disappear in adulthood, there's still 5% chances that it's not.
All right, thank you.
Mhm.
Okay. This person writes, I've had epilepsy over 50 years. Nothing seemed to work. I've never been on less than two medications. I was told when I got older it would probably get better, but it's gotten worse. I'm the only one in my immediate family that's still alive. They had neurological issues, probably strokes, Parkinson's. Should I be someone to consider testing?
Again, it's very much tailored. Let me pull up this slide, the slide with the clues. It is here. So we suspect genetic epilepsies, first of all, when seizures start early in life, if there's a normal brain MRI or a syndrome specific, if there are multiple seizure types, if there's a developmental delay or learning difficulty, or if there's a family history, specifically of epilepsy or developmental delay. Strokes and Parkinson's really don't play a role here, right? So let me just remove this slide because the duck is drawing too much attention. So I believe that in your case, genetic testing probably won't be of high yield. But again, I would suggest you to go, to your neurologist. Tell them, hey, this is the situation. I heard a lecture about genetics. What do you think about it? And just go through that information. Unfortunately, even when genetics are negative, a big, a portion of our patients or a portion with patients that have epilepsy, about a third remain drug resistant. They do end up having seizures despite optimal medical care. There are other options, so I would definitely suggest you go see your neurologist.
Great, thank you.
Mhm.
Okay. In the interest of time, there are a few questions that were unanswered. So again, um, Dr. Loushy, I will email you some of these questions, and if you can reply, then I can send it out to everybody. Yeah, a lot of great questions here. And thank you so much for your time. That was a wonderful presentation.
With pleasure. Yeah, it was great to be here, and thank you so much for inviting me. I
Thank
hope
you.
you will have a wonderful rest of your evening.
Before everybody signs off, I just want to remind everyone of some upcoming events that we have. So give me 1 second here, and I can share my screen. Okay, so on March 26th, which is Thursday, we have a virtual Purple Day meeting called Internalized Stigma and Psychosocial Health in Epilepsy from 2 to 3:30 p.m. So we have a presentation about that, and then we'll have open discussion. On April 10th from 7 to 11 p.m. at V in Philadelphia, We have our Sparking Hope, A Night Under the Stars Gala. This is our biggest fundraiser of the year. And it's a really great time, a great way to have a lot of fun with the epilepsy community and with supporters of the community. On April 13th from 6 to 8 p.m., we'll have our virtual pediatric epilepsy conference. From April 30th to May 3rd, we'll have a young adult retreat program. This is a Thursday to Sunday program at Camp Green Lane in Green Lane, Pennsylvania. Then we have our Camp Achieve from August 16th to the 21st. This is also this is the 1 week sleepaway camp at Camp Green Lane in Green Lane, PA. Then we'll have our adult wellness weekend, September 18th to the 20th. So that's a Friday to Sunday program at Deer Park Retreat Center in New Hope. All the information for our programs and services and events are on our website at www.efepa.org. And when I send out the post email, you'll have all the information and the registration for these events and programs. Just a quick reminder that we are here for you. We're here to help. So if you need to get in touch with us, you can email us at efepa@efepa.org, or you can give us a call. And then the last slide here, this is our new mailing address, and our website and our email. Thank you all so much for attending tonight. Within a day or two, you'll get an email from me with the recording of the conference, as well as information about our upcoming programs and events. And like I said, if you need anything, please reach out. Again, thank you so much for attending tonight, and I hope everyone has a good night. And I'm going to be staying on for a minute to copy down all these questions that came through.